Good morning, everybody, and thank you, all of you, for being here. So before I begin with this further details of the iris tissue repair, I would just like to say that, whenever we start with an iris tissue repair, many times we need a combination of the procedures during the entire thing, because many times I briefly categorize this as you do either a pupil-centric method or you have an iris-based repair. So these are the two basic things, and many times both of the things, they come up in combination procedures. So actually there are various methods of belling the cat. So I'll go through almost many of these procedures and I'll just show you. So to begin with, I'll just start with iridodialysis and then we move forward. So as I said, iris repair, you need to know whether you are going to adopt a pupil-centric method or you need an iris-based centric method, or you are going to have a combination of both the procedures to be done in that eye. You need to, for example, let us begin with iridodialysis first and then I come to the pupil-centric. Whenever you have a disinsertion of the iris base, you need to first assess what's the actual amount of iridodialysis that the patient has. Because many times, there are many methods of doing an iridodialysis repair. You might have to choose which one you are going to go ahead with that. So first you assess the degree. We have briefly categorized this into massive, which is more than 120 degrees of iridodialysis. If you see in a patient, we call it as a massive iridodialysis. This is moderate, which is around 45 to 120 degrees. And then we have a minimal amount of iridodialysis that is usually less than 45 degrees of iridodialysis that is present in the patient. So now, we have published many procedures on iris repair and also on the iridodialysis repair, and the most commonly that we adopt is the non-appositional repair with combination of a single pass 4-through pupilloplasty procedure. We got this published into the Journal of Cataract and Refractive Surgery, and we call this as a twofold technique because it's a combination of an iris-based repair and a pupil-centric method. So moving ahead with this, this is what we published, I think 3 years down the line. I go ahead with basic animations to show you how things work when we do a twofold procedure. Now we have this. This is a case of a massive iridodialysis. So, you have an entire fallback of the iris tissue, and it's almost like, it falls back so much that you have it coming up almost, up to the center of the pupil. So now, what actually you are seeing here is, let me go back again. I don't know how this gets paused.
No, it's not getting paused.
Huh?
It's not getting paused.
Yeah, that's what I'm wondering. No, it goes back. Sorry again. How do you pause this? ये pause नहीं हो रहा है. नहीं, वो shift हो जाता है. नहीं होता है वो. Okay, anyway, before I begin, I tell you. What we do for a non-appositional iris repair, it was described by Dr. Snyder. We use a double arm. These are the basic things which I'm going ahead with. All those people who have not yet ventured into iris repair, can people raise their hand if they are doing any of the procedures for the iris repair here? Okay, we have one or two. So anyway, so that means what I'm going to talk now makes sense. For a non-appositional repair, for an iridodialysis repair, you need a double arm suture. That is preferable. It is available in the market. You can pick up a 9-0 or a 10-0. It depends on what you want. It's a polypropylene double arm suture which we take. Now what happens is, can I have a marker? Sir, marker milega? What we actually do is...
No. Pointer.
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 Yes. Thank you. So, what we actually do with this, because this is just not getting paused, now we have this much amount of iridodialysis. So what we are going to do, we will make an entry here in the cornea, a paracentesis wound, and one needle will go from here and it will come out from this side. And the double arm, it's arm suture. So again the another needle, it will go and it will go, it will catch the iris tissue adjacent to the previous one, and then it will go on this side. It will come out from this scleral wound, the scleral margin, that the tunnel that we have created, you know, so that we can bury the sutures into that. So you have a double arm suture coming up like this. Now when you have a big iridodialysis, another, you might need 2 or 3 double arm sutures. So you can just pick up one more double arm suture and you can pass from here, come out here, again you go, come out here, and then you can just tie this up and you're done. So that is what actually this animation is all about. So this is you have a long needle for this. These are not the small needles, these are long needles. So no, you can just track it and it goes there. So now what is happening is we have done an iridodialysis repair in this, and now it's the single pass 4-throw pupilloplasty. It's a pupil centric method that we are trying to do because we had an updrawn pupil. The nuance of doing an iris repair is you should know how much amount of iris tissue you are taking into the tip of the needle. If you take too much of iris tissue, you know, you will cause retraction of iris on that side. And that is what you saw in the previous video, which Dr. Samir said, and then we needed to do a single pass to make the pupil round. So you should know how much amount of iris tissue you are taking into your needle, because then you are fixing it to its base, to its original structure. So these are some of the finer points. You know, the more you do this procedure, the more you come across it and the more you learn about it. So this is for the moderate amount of iridodialysis. Now we have these procedures going into combinations. What you are going to see now is that, you know, with this we have a moderate amount. This is a gap. So we are trying to decrease this gap. So initially we are trying to do a single pass 4-throw pupilloplasty and then do a non-appositional from the opposite side and go from here to here and then fix it up. So this is another way of doing it. Whether you want to do A first or B first depends on the clinical scenario. With a small amount of iridodialysis, you can even first construct the center of the pupil and then you can repair the iridodialysis. So that is what I just wanted to show. So this is the surgical video for what you saw in the animation right now. So now what you see here is that we need to correct this portion of the iris repair. So initially for the Twofold, we are trying to decrease this gap of iridodialysis. So what we are doing is a single pass, that is, we enter from here, we come out from the other side, and then this loop is coming out. You retract this loop out, the loop of the suture. So when you get this loop of the suture, the other end of the suture which was there, it passes through this loop. Now you have to take 4 throws, 1, 2, 3, and 4. Why not less than 4? If you take less than 4, it will open up. The knot will not be secured. It's a self-sealing knot which is created, you know. When you take 4 throws and then you pull the suture from both the sides, this knot slides inside and it goes. And then you just have to cut it. You don't have to take another pass for this. So that is why it is known as a single pass 4-throw pupilloplasty procedure. So once you have narrowed down this, you know, you can take again, do a non-appositional repair. You have taken the needle. These are the long arm needles which are used for iris repair. So we get straight ones here in our country. I'm not aware if we are getting those curved ones, but abroad they also get those curved ones which they use for iris cerclage repairs. So then you just take the suture down. Whenever you are taking a suture and tying the knot, again you have to titrate how much tight you are taking the knot, because if you make it more tight, it will again withdraw too much of iris towards the sclera, and again you will have a retraction or the correctopia, what we call, in the post-op period. So for this, whenever we have traumatic cases and all, you know, we need to do a multiple approach. So we are trying to reconstruct the pupil also on the other side. And this is again a single pass 4-throw pupilloplasty procedure which is being done. And what you see here is the knots being passed, and then you just pull the suture from both the sides. It slides beautifully and it approximates. The beauty of this surgical procedure is you do not have to do it again. Otherwise, in other techniques, like we do a modified sepsis, you need to take another pass, like again you have to pass the needle from the proximal end, distal end, and then come out. But for this, you just have to do it once. So it's comparatively, you know, a faster procedure because it just involves one single pass. So, well, having said that, I'll move on to another technique of doing an iridodialysis repair, and we call this as a flanged riveting technique. Now, what actually is done in this technique is that, before I start this, and I cannot pause this, let me tell you, we take 6-O-proline for this. A 6-O-proline suture is cut down into small pieces of around 4 to 5 inches, and then we create a flange. I hope everybody is aware of the flange technique by Dr. Shin Yamane for intrascleral fixation. So this technique has its it's probably inspired because this technique also comes from Japanese authors. So what they do is they make flanges of those sutures, which you will just see right there. So that the flange of the suture flange, it holds the iris tissue there to the scleral base. So this is the animation that explains the procedure. 6-O-proline, you create a flange and then you just compress it so that the flange, they call it as a riveting. So when you compress the flange, it becomes much more wider and broader. So now what's happening is here is that this suture is passed through a 30 gauge needle, and then a flange is created on both the sides, and then this is what it secures this into place. Similarly, it is done for the other side. I'll show you the clinical video for this. So this is the flanged riveting technique. So if you see this surgical video, this is again a traumatic cataract with an iridodialysis. So what initially we do is that we do a peritomy, you create a scleral tunnel because this is where you will be burying your flanges, or whenever we do the the iridodialysis repair, the sutures are buried into that. So this is with the cataract, so obviously cataract surgery has to be done before. It's a small iridodialysis, so you can go ahead with that. Otherwise, at times you might also need to retract the iris from the center to facilitate the phaco procedure. Now what you see is the suture, the 6-O-proline, or you can even take a 5-O-proline suture, and you take a low temp cautery and you create a flange. You have to keep it a bit far away so that you get a flange. Once you get a flange, you just have to compress this with a needle holder. So when you compress this with a needle holder, you have a wider base area. That's what I was talking before. You take a 30 gauge needle. A 30 gauge needle works very well for this procedure. We have tried it with 26 gauge, but it doesn't work very well with 26. I'll tell you the reason why. Now this 30 gauge needle is passed from this scleral wound, and it imbibes the amount of the iris tissue, and then we take up those flanged sutures, and then we just thread it into the barrel of this needle. So it just slides inside this. Once it slides inside this, you just pull it, so it drags the suture along with it. Now what happens is that you will just see that on the other side, the flange portion is coming in. So now this flange holds the iris tissue into its place, and then we also create a flange on the other side. So what happens is, you have a double flanged kind of thing which is holding. You can keep on doing this depending upon the amount of the iridodialysis you have in your setting. So you can do it twice, you can do it thrice, whatever amount of you have the degree of iridodialysis, it goes accordingly. So again, the same procedure is being repeated. That is why what we do, you have to create 4 to 5 inches of, you have to cut down the suture and then make flange and keep it ready. And then you start doing this procedure so that, you can keep on doing as much as you want. And this is how this surgical procedure goes on. The only drawback of this procedure is that, you need a very thin needle. Because if you take a needle like I said with a 26 gauge needle, I have tried this doing with a 26, it doesn't work that well. I'll show you why it doesn't work is because a 26 gauge needle, it creates a much more thicker track. It's thicker for that iris tissue. And when you go through that, you create a hole in the iris tissue which is much more. And that hole of the iris tissue does not hold the flange. It will come out like that. So 30 gauge works well. The thinner it is, the better it is. It's like that. So this is how it works, and then the surgery is over. So you just bury this, you push this into the sclera, put a fibrin glue if you have. If you don't have a fibrin glue, it's fine. You can just cover it up with a conjunctiva, and you can just cauterize both the ends, and you are done. So this is how it actually looks like. So this is, I want to show you, when I told you it doesn't work with a 26 gauge, why it does not work. This is a very challenging case which I had in my setting, and I had to do it for this. I initially started with doing this, I thought I'll do a flange technique for this patient. But many times, you know, things don't go the way you plan. So that is where the challenges come. You should be knowing other methods also how to handle it. So I begin, this iridodialysis was there since 40 years to the patient, and the patient is coming now. So you can just believe that how much amount, how the iris tissue must be behaving. It absolutely does not behave the way you want it to be, because it has been there into that position since 40, 45 years. So I'm just trying to create a flange for this suture. I have created multiple flanges, and I go ahead. Now this is a 26 gauge needle. Now see what happens. I'm trying to, this is an end opening forceps from one of the side port. It has gone inside, and then with this 26 gauge, you see this looks so big, 26 gauge needle. Actually, you know, we find it to be very thin, but no, for an iris repair, it's quite thick. You see, this is a 26 gauge needle, and it has imbibed this tissue. Everything looks fine from the other side. I'm introducing this suture, which is going inside. I'm trying to dock this, and it goes in. Okay, I'm happy things have worked my way, and I'll be able to finish off this iridodialysis shortly, but it doesn't go that way. This goes in, and it comes, and then you just see what happens. It just goes through the iris tissue, and it has just cut off from the iris tissue. It doesn't work. So you should know something else also to do. So then what I decided was, I took up this case, and I did a non-appositional iris repair. I'll show you in the next video how, you know, this video. This is the same eye which I showed you, which did not work for a riveting technique. So this was the case. More than 45 years of outstanding. The patient, patient had a history when patient was 10, 15 years old. Now the patient has cataract, undilated and dilated stage. So this is how we had this patient, and in this we started with doing the procedure. So meanwhile this video runs, I'm not going to pause it, I'll just keep on talking whatever comes in. So you can see for this case, initially I started with a triamcinolone because it's a traumatic case, and I don't know if there is any amount of vitreous coming up from any of the edges, because you know, when I showed you the undilated kind, you know, the entire periphery was seen along with the zonules and along with that. But anyway, there was no vitreous in this patient, so I was happy that, okay, at least I probably, I am better off. I only need to do a cataract and an iris repair. So this is the entire cataract procedure. I'm not going to emphasize much on this, but yes, what I'm trying to emphasize is the iris part. You need to retract the iris, and whenever you are doing an associated iris repair, iris hooks works better than any of the rings, because rings, what happen when you're putting a ring inside any of the rings, I don't want to name anybody, any ring you use, you are in a fix because you need to remove those rings, and these iris hooks are an external fixating devices, and they work very well for these cases. So this is the same video which I just showed you the clipping, that why that technique did not work. So this is, okay, I cannot fast forward it, but anyway, you will have to see that part again for the procedure. So this is the riveting flange technique which I'm trying to do. The most important part, again, what I'm trying to emphasize is, while this video runs, I will not repeat what I said, but I will try to put on the emphasis that, see, the amount of iris tissue that I'm taking inside. You have to be very careful of this aspect if you are going to do, if you are just starting to do an iris repair procedure, any iris repair procedure, the amount of iris tissue that comes into your needle is very important. Second thing that I want to emphasize is, your needle should not imbibe a corneal tissue, a cornea, because see, when this needle is coming, it looks simple that, okay, she's passing a needle, okay, nothing great, but actually it is great, because that needle should not be carrying any of the corneal fibers, imbibing the corneal fibers, because I don't know if you understand, you have a double arm suture coming in. So you have one and you have another. Now when your first needle goes in, and if it has a corneal fiber along with it, you know, the thing will not slide inside. It will be a failure of the entire procedure. So you have to be very careful of that aspect also. You can create a paracentesis wound, and you should be very careful that when you're pulling the second needle also, your loop slides through the paracentesis inside. It should not remain there itself. Otherwise, it doesn't slide. You try to pull it, and you will create further more iridodialysis on table. So what you actually saw was the non-appositional repair, wherein the needles were coming from that side, and I just sutured them here. So that worked fine in this case. And now you can see this retraction of the pupil here. So I have created one paracentesis here. I already had an opening here, so I used that opening, and I'm trying to pass the polypropylene polypropylene suture from proximal part, from distal part, and it comes out from here. And then we just take a loop outside, 4 throws, and it slides back inside. So this is a bit hazy because there is a bit of inflammation, there is a bit of hyphema out there because, you know, we had a lot of manipulation in this patient because the initial procedure also failed. But this looks pretty good because this iris tissue has come up together. But I also have a defect here coming in. So I'm repeating this procedure again because I need to close this defect also. So again the same thing, I pass from the proximal distal part and I come up. This is very important stage. No corneal fiber should come up. Your suture should be totally free. Now this is the loop from the other side which is being pulled out, and through this loop the suture end, which already has a needle in it, I'm passing it with the needle in itself. I'm trying to save my suture, to be very frank, because if I cut off the needle at that point, you know, and if this doesn't work, I'll have to use another suture. But you can cut off the needle and you can do it if it's uncomfortable. So this is how it looks. It looks pretty good in the post-op period. This was the pre-op, this was the post-op. Patient no more has glare, so this is the best that we could do for the patient, and the patient is quite happy with that. So when the patient is happy, the surgeon is also happy. So this is how we went ahead. We have one more procedure. Now coming up to the point of, you know, using, this is a trocar-assisted hangback repair. We have a simple hangback. The non-appositional method is also known as a hangback method. So this is a trocar-assisted hangback. Why did we introduce this trocar-assisted hangback? Because there was an issue of, you know, the corneal fibers getting engaged while passing the needle through the cornea. It used to fail, but this technique ensures that it doesn't happen. So the concept is to prevent the entrapment of the corneal fibers into the suture needle. And what you actually need is a 25 gauge trocar or a trocar anterior chamber maintainer. That's the only thing that you need this device to do it. So I'll just show you the animation. In this, whenever you have iridodialysis here, so you will put a trocar in the opposite quadrant. We always try to work from the opposite side because it's comparatively easier to pass the needles and do the procedure. So what we actually do in this is we just place a trocar, and now both the sutures, you know, the double arm suture will pass through this trocar. So the trocar prevents any entrapment of the corneal fibers coming up. But the point is that you need a trocar to do that. We have modified this into, you know, if you do not want to use trocar because trocars are costly, what I often do is that, you know, I would just place a iris spatula, which we always have in our clinical setting. You can put an iris spatula like that on the corneal incision, and then you can slide the suture very closely to the spatula, so it directly goes inside. You know, it will not entrap the corneal fibers because then you're not juggling to push it inside. Many times, many complicated eyes, you know, things, they become really complicated at times. So we need some small tips and tricks to help us out at that moment. So this is one of them. You can use a trocar if you want. If you know how to put a trocar, it's well and fine. If you don't know, you can use this trick which I just told you. You can just place in a iris spatula and you can pass the suture needle above it, and you can go ahead with that. So now what I'm trying to show you is the application of single pass 4-throw pupilloplasty procedure. I don't know if people, how many of you know what actually a Ure-Zavalia syndrome is? Ure-Zavalia syndrome is a persistently dilated pupil that you have in the post-op period. What actually, it was described by Ure-Zavalia. He was the scientist, I think he was from Brazil or Argentina, and he described it. There were cases of Ure-Zavalia syndrome. Have you ever come across doing a very fine surgery and next day seeing the patient with a dilated pupil? And it does not respond to miotics? That is Ure-Zavalia syndrome. These are the cases. We all have come across it, but we are not aware of it. What actually happens in these cases is, there is a persistently dilated pupil. In the initial phase, it remains okay, but then the patient starts having raised intraocular pressure, and slowly it keeps on decompensating as time goes by. Now, what actually is to be done in these cases is surgical pupilloplasty. You need to pull the iris tissue from the periphery to the center. So, that is how surgical pupilloplasty works for a Ure-Zavalia syndrome. It has a total clinical application. This is the anterior segment OCT, which shows the closed angles. Now, this is a case. This is the animation. This actually shows what actually happens is, you pull the iris tissue, so it increases the trabecular meshwork outflow, and it prevents secondary glaucoma from happening in these patients. But you need to catch these patients very early before they go into a chronic stage. When you do a surgical pupilloplasty, initially these patients, they respond very well. But once they have those raised intraocular pressure and other settings coming in, then things become very difficult for these cases. So this is post-PK persistently dilated pupil in this patient, and now we are trying to do a surgical pupilloplasty for this case. So this is one thing which I wanted to show you, that it also has other clinical applications. You can do any other technique apart from single pass 4-throw pupilloplasty. If you're well versed with it, it's fine. We try to do this because it's simple, easy, fast, and you just need one single pass and you are done with. And because these are all complicated eyes, you don't want to again go ahead at the same location and again take a suture and again do that. You do it once and you are done. You see this, the pre-op and the post-op opening up of the anterior chamber angles on the anterior segment OCT. This is how many times the pupil comes in. Persistently dilated pupil, not responding to any drug, and you are in a fix that what to do with this case, because you did not do anything wrong in the surgery. There was nothing wrong with you, but this syndrome has been described. Nobody knows why it happens, but it happens. So next time you see any persistently dilated pupil following any surgery, it has been reported not only after not only after cataract, but initially it was reported after penetrating keratoplasty, with DALC, with cataracts, with many other procedures. It has been described. So this is the basic point, that if you do a surgical pupilloplasty, it works very well. And how it works is that this pupil reconstruction, it pulls the peripheral iris tissue from the periphery to the center. The forces are directed towards the center, and it has been demonstrated to open the anterior chamber angles on anterior segment OCT and also on intraoperative gonioscopy. I think Dr. Agarwal will be covering that issue. So there are various other advantages also that we have documented in peer review with the single pass 4-throw, that is even with the endothelial keratoplasty, because as I said, we do not take a second pass, we only have a first pass. So practically speaking, the loops of the suture, they just remain very close to the iris surface. You do not have any knot coming in. It's a self-sealing kind of thing with 4 throws, and it goes close to the surface of the iris tissue, which we have demonstrated again on the anterior segment OCT for these cases. So it works brilliantly, especially for endothelial keratoplasty cases, because when you have a moderate amount of anterior chamber depth and you are doing an endothelial keratoplasty, your tissue is going inside. So it works really well for these cases because what happens is that you do not actually have those protruding knots coming in, and there are less chances of it hitting your corneal tissue graft at that point of time. So Well, I showed you about single pass and everything. I showed about the Ure-Zavalia. I will just show you other techniques which can be adopted if anybody is interested. That's a modified Mac canal. I'll show you the animation for this, how it actually works. So you have an iris defect here. So in that, it's simple. You make this paracentesis, you pass the needle here and here, you pull both this out, you take a suture, tie it, and it goes like that. So this technique is a modified McCannell method. I'll show you this. This is an iris, this is an encerclage. But since we have started doing single pass for throw, we actually do not do this procedure anymore. This is just for academic interest. It's a suture that you pass all around, and then you pull this out from the suture, and then you tie it. There's an advantage to this, that maybe you get a much more rounder pupil, but it's much more technically demanding. So initially, we need to go ahead with simple procedures that can be done. So I think I would like to end my talk with this. Thank you so much.
SFT, single pass four throw pupilloplasty, which is a beautiful procedure which Dr. Agarwal and Dr. Priya have come and yeah. Yeah. You pass 9-0 proline or 10-0 proline from one side of the from cornea, from the proximal end of the iris. You take the through the railroad technique, or directly you can take it through the distal end of the iris, bring it out from the other end of the cornea. Now with the from the paracentesis opening, you pass a Sinskey's hook and make a loop. So single pass, you are making a loop, and from that loop you are passing the loose end of the suture 4 times. It has to be, if you are passing it like this, it has to be same side. You cannot one loop like this, second like this, suture, 4 loops from same side. So, and then you have to pull both the sutures gently. So that is single pass 4 throw pupilloplasty, because
Come from the corneal side, not from the sterile side.
from this cornea
For
both.
example, this is an iris defect. I'll just show you right here. This is an iris defect, and you need to close this, right? This is the corneal margin, the limbus. You make a paracentesis first, okay? This is the needle. The needle goes from here, okay? I'll put a hole in this. The needle goes from here, then the needle passes from here, from the other side. The proximal and the distal, okay? The needle is through it, but these tissues are still far away. They are still like this. So this comes out from here, okay? Now what you do is, I take a Sinskey's hook from the paracentesis. You go inside, and this loop, I'll go from here, from inside, and I'll bring this loop from this paracentesis out, and then the suture with the loop goes here, and then we pull both, and then it automatically slides. So that is, yeah.
One important point I would like to say, I have seen many surgeons, they are making 2 paracentesis opening. There is no need to make 2 paracentesis opening, only 1 paracentesis opening from where you have to bring the loop out. You get my point? So only 1 paracentesis opening from where you take the loop out, and then
You can be a left-handed or a right-handed surgeon. We are talking
so
from a
no need to
right-handed
make a
surgeon's point of view.
two
You go from
paracentesis.
here.
So now we have Dr. Amar Agarwal. Yeah. Any questions? Yes, sir.
compared to the viscofield ACs.
Good question. Very good
Yeah.
question.
You can you can do it with a viscoelastic, you can do it with a fluid infusion. Depends what you are doing, what is the clinical setting. For example, if you are doing a routine cataract with an iris repair, you are already using an OVD inside the eye, you already have it open with you. So you can go ahead and finish it off with that. If we are also doing it with complications like, when we have a rupture and things coming up, and then we have to do an iris repair, at that point of time we have fluid infusion inside the eye. So when we already have a fluid infusion, and we do not use OVDs, when we have those secondary oil fixations coming up and all those things. So in that setting, we do it with a fluid infusion. So it works that well. You can do it with a fluid infusion also, but I'll tell you one thing. When you're doing with a fluid infusion, you might have it a bit, a wavy, a shallow kind of thing. So maybe if you are beginning to venture into doing a pupilloplasty with a simple cataract procedure or without a cataract procedure, whether if it has already been done, I think you would be much more comfortable with doing it with an OVD.
Because what my experience is that after putting, especially while the iris repair, I tend to inject pilocarpine, stretch out the iris, and then do the repair. It works better in a fluid-filled AC. And also when you pass the needle, if it goes through the iris route to control the bleeding and all, so as to raise the pressure, change to air, I think the saline fill will be more advantageous as compared to a visco.
Absolutely, it's a combination. It works well.
And
You
if
can
you are
go
doing
ahead.
glued IOL or secondary IOL like we are doing intrascleral fixation of the IOL, then you cannot use viscoelastic because that is going into the vitreous chamber. There you have to put the anterior chamber maintainer.